There we go. Good morning.
It's nice to meet you. I have one shared patient with you that thinks that, with good reason, that you are the best doctor he's ever had. So,
Oh my.
I'm excited to get a lecture from you yourself.
You'll have to let me know what patient is so mistaken.
Usually people trickle in the kind of the next 2 or 3 minutes, but if you want a chance to practice getting your slides or make sure that your slide share works, we can troubleshoot that if you'd like.
Sure, let me do that. Let me change the let me change the display settings. How does that look?
That looks perfect. I can see it. Let's give it maybe 2 or 3 more minutes and then we can get started if that's okay with you.
Sure. For the record, I took that picture myself.
No copyright infringement.
No, can't do it on my own pictures.
It's a good shot. I'm impressed.
The iPhone can do amazing things.
Morning, Dr. Hirsch.
Good morning.
Yeah. Nikki, for you and for the rest of the group, our surprise second half is Ken. Ken will be doing a talk on pleural disease. That's what he thinks. And so if you're trying to text him now, he may be working on some slides, but it will be Ken Steinberg as our mystery second guess.
There was a lot of hype on what it could be, so.
I hope it's not disappointing to people.
We're getting closer. I think we're kind of nearing a critical mass here, John. I'm not sure what you think.
No, let's go forward.
Um, Residents of Gitku, I'm excited to introduce Dr. Irl Hirsch, who is one of our excellent endocrinologists here at UW, takes care of a lot of patients with diabetes. And if you've ever met one of his patients, they will let you know because they all kind of universally love Dr. Hirsch. So I feel so lucky to be able to learn about insulin from him today, and we'll let him take it away.
Great. Thank you very much, Nikki. It's been a long time since I've spoken to the residents, and it's a topic maybe we can talk about later. Getting more residents seeing endocrine patients and especially seeing diabetes patients. A little bit of history. I came here 33 plus years ago, and there was no diabetes clinic, and the whole idea was to open a diabetes clinic um, where we would um, both see patients with diabetes and participate in clinical trials. And the goals, I think, were accomplished. Right now, in our Diabetes Institute here at South Lake Union, we do about 15,000 patient visits a year. Half of them have type 1 diabetes, and of the type 2 patients, give or take 80+% of them take insulin, which is why this is a great place to learn how to use insulin. And we also see quite a few number of patients with atypical diabetes, neither type 1 nor type 2. It's actually an area we are doing quite a bit of research on right now. And the other thing I just want to say in my introduction is I just had a meeting with my research um, the person who runs my research team, Dori Kakpour. Dori's been with me for almost all of those 33 years, starting with me as one of our nutritionists, both on the clinical side and the research side. And we've been together through this journey for many years. And I invited Dori because I thought she'd be very interested because we learned how to do a lot of this together. We were involved in much of this research in terms of how people around the world use insulin today. So with that introduction, I was an endocrine fellow in the late 1980s at Washington University in St. Louis, and this would never happen today, but we were given as a gift from Eli Lilly this book. And the book was The Discovery of Insulin by Professor Michael Bliss at the University of Toronto. Now, many years after this, I got to know Dr. Bliss very well. He wrote the story of Banting and Best and the discovery of insulin. And one of the quotes from the book was, with insulin, the stone was rolled away, and diabetes became a matter of the quality of life, not the speed of death. And it's often hard to fathom the fact that insulin and its discovery is not that long ago. And what's more interesting to me when we look at the history of insulin after its discovery, that most of the real changes in therapy have occurred really in the last 30 to 40 years. This is what insulin looked like. And when it came from those the first factories in Indianapolis, notice it was U10, U20, and U40. And even in fact, back in the 1970s, it was all U40 and U80. We didn't have U100 like we do now when it was all standardized. But the important part here is all this muck you see at the top and the bottom, that actually is what the insulin looked like, because there was so much impurities in it. And if you're interested in the history, what you will find out is that the potency of this insulin was extremely variable. And because they could develop this isoelectric precipitation, the insulin became more consistent, more potent, but realize that even though it decreased the variability to 10% with this isoelectric precipitation, realized that all of the insulin came from cows and pigs. And because of that, there was a huge concern back in the 1950s and 1960s that we would run out of the ability to make insulin. The history of insulin is extremely interesting, but just without going through any of the details, please appreciate that most of the major advances in insulin has really been since the early 1980s, when we uh, were introduced with the first recombinant DNA human regular insulin in 1982. The insulin was very, very dirty until the 1970s. And in fact, when U500 insulin was introduced in 1952, and I know a lot of you have experience with U500 insulin when our very insulin resistant patients come in onto the inpatient side, the reason why U500 insulin was even developed was not for these insulin resistant type 2 patients or the syndromic patients, which nobody even knew about back then. The reason why is for the high antibody titers in the type 1 patients and just trying to get through the neutralizing antibodies to get to the insulin receptor. That is the reason why there was the U500 insulin. And as a matter of fact, when the U500 insulin was developed in 1952, the question was, should they actually also develop a U5000 insulin? And U5000 insulin was on the drawing board. Fortunately, it never came out. Think about the potential nursing errors on the inpatient side today with U5000 insulin. Now, what everyone needs to know about insulin therapy, that you have to know how to use it. In the United States, 13% of patients with type 2 use insulin with other agents, 14% use it alone. So if you look at today's diabetes numbers, that's over 7 million people with type 2 diabetes and another 1.5 million with type 1 diabetes. And that 1.5 million now is probably closer to 2 million with type 1 diabetes. So as a general internist, and this is going to come up again, you really need to understand this. While the insulin analogs, it's really improved the risks for hypoglycemia, both in type 1 and type 2 diabetes, providers need to understand how to best use human insulin for those who can't afford the insulin analogs. Now, the good part about this bullet point is that the insulin analog pricing, due to a lot of things happening in Washington, D.C., more than anywhere else, things are getting better depending on what zip code you live in and what state you live in. We're not hearing about DKA and deaths from insulin rationing like we did 2 or 3 years ago. There are still many people who can't afford the retail prices of insulin, but this problem in the United States appears to be getting better. Um, I'm very happy about this. I actually testified to Congress twice about this problem, but this is more of a political problem than a medical issue. So this is what happened in 1982. Both Eli Lilly and Novo Nordisk developed human insulin, and this was a big deal. I was a medical student at the time, and we all thought that this was really going to change diabetes forever. And I think the bottom line from this is it didn't change it like maybe people thought it would, but we don't run out of insulin now because of not enough animals. And then we had the insulin analogs. They came first in 1996 with insulin lispro. I remember that very well. We were not involved in the insulin lispro trials and the registration trials. I was involved in the aspart trials. And again, lispro, just so you know, and you have to know this, and we're going to get to this in a moment. Lispro is Humalog, aspart is Novolog. We were involved with the glulisine trials back in the day. We don't use that very much anymore. Then the faster acting insulin aspart, that's Fiasp. Lispro AABC, we use quite a bit here in our clinic now. That's Lumjev. And we were involved in the glargine trials. We were involved in the Detamir trials, concentrated glargine, Degludec. In fact, I am told this part of the country is in the United States, we use more Degludec than anywhere else in the United States. That goes by the trade name Tresiba. And of course, we are a long way from human insulin, as these are just modifications in the insulin molecule. And the issue is, as a resident, you need to understand how the kinetics of these are different and the same from each other. Now, it's my belief what you need to know is that we have these human insulins, and there still are times, taking finances out of the equation, these insulins are better to use for one reason or another. The most common reason we use NPH insulin, even on the outpatient side, other than the fact that you can get it for 25 bucks a vial at Walmart, is the fact that this is a wonderful insulin to use for patients who are on morning prednisone for whatever reason. And it has to do with the fact that the kinetics of the NPH and the kinetics of the prednisone are about the same. The fact that as long as you're below somewhere between 40 and 60 milligrams of prednisone, you're not going to have much of an impact on fasting glucose, because the glucocorticoid has a greater impact on the muscle than on the liver. And because of that, you have a greater impact in postprandial glucose than with fasting glucose. So there are times we use more NPH. I think the most common time we still use regular insulin is with IV insulin. There's no advantage when you're using IV insulin in the hospital to use an insulin analog. Now, this is what's important for you as a resident. You need to know what the trade names are, because we have seen over the years all kinds of mistakes. There is a patient I follow to this day who probably 15 or 20 years ago, he was admitted. I don't remember why he was admitted. He was on IV insulin, and he and the resident couldn't decide what insulin he was on. The resident didn't know the name Lantus, which is glargine, and the patient didn't know glargine, which was Lantus. But they both knew what NPH was, so he went home on NPH, and literally his first night home with that big slug of NPH at bedtime, he had a middle of the night hypoglycemic seizure. So knowing the names of these insulins are important. And what's happened with glargine is that we now have, we now have 4 of them, 4 different brands of glargine in the United States. And the important thing to know is that there are sort of quirks with all of these insulins. There are general comments we're going to get through with these insulins, but there are quirks. Let me just give you one example. We don't use Detamir very much. Even when it came out and it was marketed, I didn't like it. And one of the many, many reasons I don't like Detamir is that for patients who have a BMI over 28, now talk about esoterica. If you have a BMI above 28, Detamir is not a unit per unit transition anymore. Detamir, turns out you need more than a one-to-one conversion if you're converting from glargine or NPH. Every one of these insulins have these little quirks that we've really gotten to learn quite a bit about with continuous glucose monitoring. We see these quirks. We don't use a lot of these premixed insulins anymore. We use them sometimes, especially with type 2 diabetes. And there are situations that they work quite well, where you have 70% NPH, 30% regular. It's 75% NPL, which is the same as NPH, 25% Lispro. We also have a 70% NPH, 30% Aspart. There are a few of these. But the bottom line is we use these sometimes. Usually when these patients come into the hospital, we will just switch them to a basal bolus type of insulin therapy to make it easier and more flexible while they're in the hospital. And something that we probably don't use as much as we should for type 2 diabetes are these combination GLP-1 long-acting insulin combinations, where you have degludec and liraglutide as one injection, glargine and lixisenatide, which is another GLP-1 receptor agonist from Sanofi. We're going to talk a little bit about these at the end of our discussion, but these are really great options for patients who come in who you want to put on a basal insulin and a GLP-1. So some basic principles of kinetics. We talk about pharmacokinetics, and what's really important is to understand the difference between pharmacokinetic and pharmacodynamic. And this isn't just true with insulin, it's really true for any drug. A pharmacokinetic is just measuring the drug in the blood after administration. Now, you can just measure insulin levels, is what we usually do. Sometimes you can actually measure the drug level. So you can measure the amount of Lispro or measure the amount of glargine. But this is just measuring the drug in the blood. This is what we usually talk about, pharmacokinetic, but whether you're a clinician or a patient, what you are more interested in is the pharmacodynamic. And this is a measurement of the biological drug action. Because what happens is you can measure the amount of insulin in the blood, if we're talking about insulin, but that's not what I'm interested in. Once the insulin gets into the blood, it then has to bind to a receptor. It then binds to a receptor, whether it's a muscle cell, whether it's a liver cell, and then all these things have to happen with a glucose transporter to get into the cell. And then once it gets into the cell, all these other things have to happen. And from a patient point of view, that's how the blood sugar goes down. And from a timing point of view, the pharmacodynamic is the more important time. Yet when you look at the package insert and the labeling of the drugs, they usually show you the pharmacokinetics, which is going to be a much shorter time than the pharmacodynamics. So to figure out the pharmacodynamics of insulin, we need to do a glucose clamp. And what a glucose clamp is, you give a dose of insulin, 0.2 units per kilo, 0.3 units per kilo, whatever it is, and then you are infusing insulin. And this insulin infusion, you're infusing glucose. And this glucose infusion rate is measuring the action, the biological activity of the insulin. And that is the pharmacodynamic of insulin by looking at that glucose infusion rate. Now, the half-life is very different because the half-life is the amount of time for half of the drug to be metabolized and to get to steady state. And again, this isn't just insulin, this is just in general. To get to steady state, you need 4 or 5 half-lives. So if you have a half-life of a day, it's going to be 4 or 5 days. If you have a half-life of a week, like we have with thyroxine, when we give T4, not T3, but T4, it's going to be about a month when you change somebody's T4 dose to get to steady state. So you don't want to measure the TSH. I don't want to get too much into thyroid, but as an endocrinologist, I think about this stuff a lot with all of our drugs. So this is the pharmacokinetic. This is an old study, but it brings the point out very well. If you just measure the insulin level, Lispro in the white, you have this peak a little bit less than an hour, and after 3 to 4 hours, it's pretty much gone. And look at that compared to regular insulin. With regular insulin, all you have here is you don't even have much of a peak. But importantly, you give regular insulin to somebody in the hospital, you have um, this insulin measurement in the blood for 5 or 6 hours later. But that's pharmacokinetic. I said a minute ago, we don't care about pharmacokinetic. What about a glucose clamp? Now, aspart and lispro are identical in terms of their kinetics and their dynamics. And this was the best study just to show as an example of injecting 0.2 units per kilo, looking at the glucose infusion rate on the y-axis. And I want you to look at regular insulin in the red. Note that it has a peak almost 4 hours later. And at 8 hours later, at this relatively low dose of 0.2 units per kilo, you still are infusing glucose, and that's 8 hours later. Now, think about regular insulin as a mealtime insulin. It doesn't make a lot of sense if you're eating a bagel and maybe having a glass of orange juice. Hopefully, if you have diabetes, that's not what you're doing. But if you do, it's not going to work very well because the peak of this insulin is literally 4 hours later. By the same token, if we look at our quote unquote rapid acting analog with aspart, it's better, but it's still not going to handle a bagel very well with this plateau of a peak about 2 hours later. And this is really a slide I really want you to remember. And this is the reason why, as you'll see in a moment, when you're using aspart or lispro and you're treating somebody prior to their meal, you don't want to give their insulin and have them eat right away, let alone giving their insulin after they eat, because this insulin is so slow compared to how quickly people absorb carbohydrate. A bowl of cereal in the morning without any protein to slow it down, those patients, no pun intended, they're toast. They spike to 300 every time because it's too much carbohydrate. The insulin isn't going to peak for hours later, which is why we are using faster acting analogs now. In fact, we are doing a study right now with pulmonary inhaled insulin, which is in and out in 90 minutes. It's completely different because these insulins are so slow. And what happens when you give these rapid acting analogs at high doses, note we're not measuring insulin. Here we are measuring lispro. I say we. But the investigators are actually measuring lispro. And I want you to note when you're just measuring the pharmacokinetics, you have this lower insulin peak in with 10 units in people with type 2 diabetes than 10 units in people without diabetes. And what you see is the peak is prolonged and it takes longer with these bigger doses of 30 units and at the top 50 units of insulin lispro, you see these greater peaks, but the curve is moved to the right. It takes longer because it's a bigger surface area. It's all about the surface area. And it's pretty amazing that if you look at 50 units in these people with type 2 diabetes, you're actually measuring lispro levels here 400, 420 minutes later. And if any of you have ever taken care of an insulin overdose, which we see sometimes from suicide attempts, and they take huge doses of insulin, those patients need to be on dextrose strips, sometimes in the ICU for days, depending on what type of insulin they have injected. And we've seen that many, many times. Now, this is the point about what we term the lag time. The lag time is the amount of time between giving the insulin and eating the meal. These are two different studies. The first one is with Lispro. The second one is with glulisine. The insulin kinetics are the same. Now look what happens if you give the insulin 15 minutes after eating. You have this big spike. These are the same patients on different days. If you give the insulin when you eat, you have not quite of a spike. If you give the insulin 15 minutes before eating, it's the yellow. If you give the insulin 30 minutes before eating, you're pretty flat, which is what you want to do. And I'll just point out that, where you really want to see this, I mean, you'd obviously like to always see this. It's not always possible, but I will point out this is what you want to see, not with a baseline of 180, but this is what you want to see in a woman who is either trying to get pregnant or is pregnant. You don't want to see any spikes because that's the situation, that those postprandial spikes are bad for the baby. But the point is, if you really don't want to see a spike and you're eating a fair amount of carbohydrate, you can do away with the spike even with these older fast-acting analogs by giving that insulin time to act. We did a study we published in the New England Journal in 2008. It was the very first study funded by the Juvenile Diabetes Research Foundation, and we showed this dramatic improvement in glucose control in patients wearing sensors compared to without. And the number one reason for that improvement in glucose control is the patients saw the difference in their blood sugars when they waited before they ate compared to giving their insulin and eating right away. And think about that when patients in the hospital are given their insulin after they eat. Because a lot of times you do that because you don't know how much they're going to eat, or you may do it because the nurse hasn't had time, whatever the reason is. But the timing is really the key point here. Now, look what happens with glargine. We're again looking at pharmacodynamics, that is glucose infusion rates of glargine given into the abdomen. And we're doing this at different doses. What we look at here is if you don't give any glargine, you're not going to infuse glucose. Well, that makes sense. This is if you give a half a unit per kilogram. It's relatively flat, but it's not flat. The glucose infusion goes away after about 18 to 20 hours. 1 unit per kilogram. Now, that's a big dose. If you're talking about a 70-kilo person, let alone many of these patients weigh 100 kilos, that's 100 units of glargine. And note that it actually does have a peak, and it's pretty much gone after 22 hours. But look at 1.5 units per kilo and look at 2 units per kilo. And when you look at this, what you see is you still have a lot of insulin activity at 24 hours. Understanding the more typical dose is 0.3 to 0.4 units per hour in most patients. But what's interesting about this, when you do the statistics, you don't see any difference in the glucose infusion rates between 1.5, and 2 units per kilo. You do compare to 0.5 units per kilo, but they're not different than each other. And in fact, there's other data showing that once you get with glargine above 0.7 units per kilo, once you get above 0.7 or 0.8 units per kilo, you don't get any further improvement in glucose lowering with this glucose infusion rate. And that's really important when you're dealing with very insulin resistant patients. Now, here's the trick, and I'm not going to show you. The data from this comes from Poland, but what's very interesting is that it all has to do with the surface area. If you're going to give the same dose of insulin in 2 or 3 injections, you do get higher glucose infusion rates. And that's sort of the trick. When I used to do inpatient, we did this all the time. If somebody's getting 80 units of bedtime insulin, instead of giving 80 units in 1 injection, we'd give 80 units, but we would give it 40 units in 2 injections, and we'd get a much better glycemic response because you increase the surface area of that insulin depot. So, although it is possible that the duration of insulin action is prolonged with increasing the doses of glargine, There is no difference in insulin action for the 24 hours after injection once you get above 1 unit per kilo, and it's actually 0.7 units per kilo. So these are things you need to think about, and this in particular for those very insulin resistant patients in the hospital. So let's talk about some pearls of basal insulin. At the usual doses, glargine won't last 24 hours, which is why most with type 1 diabetes, we take it twice a day. We have patients take it twice a day. You can do it twice a day in type 2 diabetes, but in the type 2 patients with the bigger doses of insulin, you actually do get a twice daily usage. Now, if you see somebody with type 1 diabetes and they're taking it once a day, or they only want to take it once a day, taking it at bedtime usually works okay because it's their dinner short-acting insulin that is covering the problem with glargine not lasting a full 24 hours. The typical patient without renal disease, you give the glargine in the morning. If they're C-peptide negative, they sort of fall off the cliff between 3 and 4 in the morning, usually anyway, and they don't do well. They wake up very high and maybe even occasionally ketotic. I mentioned we don't use a lot of Detamir. It has a shorter duration than glargine. And with this insulin, you almost always need twice daily insulin in type 1 diabetes. Now, here's one of those little things you have to know about if you use U300 glargine. And we use a lot of this because it's considered an ultra long acting basal insulin. But here's the problem. It only comes in a pen, which is a good thing, so there's no risk of mixing it up. But you need between 15 and 20% more insulin unit per unit. So if you are switching somebody because it's a very long 24-hour insulin, there's less hypoglycemia with this, which is a good thing. You need unit per unit. If you're switching them from regular glargine or NPH or Detamir, you're going to need 15%, actually 20% more insulin, and you need to know that going in. Degludec in both type 1 and type 2 diabetes, and like I said before, we use a lot of it, less hypoglycemia than glargine, but it can be tricky to use. Think about this, a 25-hour half-life. That means if it's 25 hours, 4 half-lives, we're talking 4 days to get to steady state, and then you want to look another 3 or 4 days after that to look at patterns. This is not something you can usually titrate easily in the hospital. It lasts 42 hours. And this is the PK. I published this with a colleague from the University of Chicago, University of Colorado, in the American Journal of Medicine, but it takes a long time to get to steady state with Degludec. Now, let's talk for a minute about type 1 diabetes and some pearls you need to know. Nationally, over 60% now with type 1 is using continuous glucose monitoring if we look at all of type 1s, while 40% are using pump therapy if we look at all of type 1 diabetes. Here in our clinic in the UW Medicine Diabetes Institute, of our type 1s, it's over 95% use continuous glucose monitoring, while over 70% use a pump, almost all with automated insulin delivery, where the sensor tells the pump what to do with the basal insulin on the pump. We're not going to get into this into too much detail, but you can't be afraid of this when these patients come to your clinic or you see them in the hospital. If this is over 70% of our patients, and we're around 40% of these patients in the United States. About 50% of newly diagnosed type 1s occurs in adulthood. I can tell you, at least here in the Seattle area, about 90% are misdiagnosed as having type 2 diabetes, even when they may have an identical twin or a parent with type 1 and they're not obese, they're still misdiagnosed. But nevertheless, I won't get into any editorials or ranting about that, but you need to always be suspicious when you see someone who's not meeting the usual criteria, they're not responding to metformin. Could they have type 1 diabetes and be very insulin deficient and not insulin not insulin resistant. Not insulin resistant. It's about 50% of all newly diagnosed type 1 are now adult onset type 1. Now, this is data that we published that for adult onset type 1s, the autoimmunity is very different than it is in childhood onset. And what we showed is without GLP-1s, without doing anything fancy, 40 years later, 23% of these adult onset type 1s are still making a little bit of C-peptide. Um, and, and that's why looking at C-peptide by itself in these adult onset type 1s, you may not know the whole story because 23% are still making a little bit of insulin after 40 years, but they do have autoimmune type 1 diabetes. Now, here's the other thing. Typically, we have these patients coming into our clinic for the first time, and they're on 70% basal insulin. And for most patients, they're not trying to gain weight, they're not trying to lose weight. Things are a little bit different in adolescence when insulin requirements go way up. But for the average patient, between 40 and 45% is basal insulin. And the question is, how do you come up with basal insulin dose? Most for total daily insulin require between 0.4 and 0.8 units per kilo per day. Most with type 1 diabetes when they're C-peptide negative. Now, this is really important when we look at weight status. When I was a resident, when I was a medical student, we would say, well, type 1s are thin and type 2s are not. And that's not the case at all anymore, because what we see with every single age group is that we see, especially in the adults, we see the same amount of people overweight and obese as we see in the general population. About a third overweight, about a third obese if we use a BMI of 30 as the actual number. And so you can't use body weight like we used to as a way to make the diagnosis. And the question is this trivia? Why, as a primary care internist, or maybe some of you will be going into cardiology or GI, why do you need to know this? Well, the answer is right here. If you look at the counties with blue, the counties with our blue, the counties without our white, at least one primary care physician or endocrinologist. The blue is every county in the United States with a primary care physician. And on the right is every county in the United States with either an adult or pediatric endocrinologist. And especially in the middle of the country, it's pretty barren if you're trying to find an endocrinologist. And the reason why this is so important, especially for you who are staying in general internal medicine, is that primary care physicians manage 50% of the adult type 1 patients in the US. Not the pediatric patients, but once they get into adulthood, these are your patients, they're my patients, we share them, but the primary care physicians are the primary providers for half of the adult type 1 in the United States. That's about 750,000 people. And especially if you live in one of these counties that doesn't have an endocrinologist, you are going to be taking care of these type 1 patients. So the basic premise is that we want to give a background insulin, glargine, detamir, degludec, and we give a rapid-acting analog. And we helped develop this back in the late 80s and early 1990s, but this is what you want to think about, how to best replicate normal physiology. Most, again, require 40 to 45% basal insulin. There is some variability, especially we have a lot of patients now eating low carbohydrate diets, so that may not work. Basal dose can best be calculated by the Beam score. We're going to get to that. It's the bedtime glucose subtracted by the morning glucose, the averages. And in type 1, you want that to be under 30. So if you go to bed at 150 on average and you wake up at 140 on average, the difference is 10. That means the basal insulin, whatever you're using, is working great. Most coming into our clinic are on multiple injections. That's MDI, multiple daily injections. I was going to make this as a multiple choice, but The joke is LOL. If it's my daughter, LOL is laugh out loud. If it's internal medicine resident, LOL in the chart note is little old lady. If it's an endocrinologist, LOL is living on Lantus. And the reason is we have years and years of all these patients with type 1 diabetes taking 80 and 90% of their insulin as basal insulin. They're just living on it. And it's very hard to get their blood sugars under good control when they do this. The other thing about type 1, we have estimated prandial doses with carbohydrate counting, but now we're moving more into meal estimation where you can talk about low, medium, or high carbohydrate content of the meal. And it actually works pretty good. And the reason is that carbohydrate counting is fraught with you have to it is an estimation. It is difficult. The protein counts as calories also. You need insulin for that. And we are finding that meal estimation is actually working just as well. We have really good evidence for this in type 2 diabetes, not as good of evidence yet in type 1 diabetes for that. We now have 3 smart pens FDA approved, which greatly help us with our patients. This is one of our smart pens. And the way it works is that you have an app on your phone based on this insulin settings. We help the patient put into the app, and you put in the amount of carbohydrate, or you can put in medium or high carbohydrate meal. You have a sensor, you put in the glucose level from the sensor. It calculates a recommended dose of insulin. You give the insulin, and then the pen Bluetooths into the app. So it continues to count how much insulin on board. So if you want to give an insulin for a high blood sugar 2 or 3 hours later, you know how much insulin is on board. The app does. You can put in the glucose and you're not stacking the insulin. And that's the big problem, which is why we don't like to give a lot of between meal insulin in the hospital, because you're always stacking the insulin. And these pens really help patients not stack the insulin, which is why we use them. These pens talk to the CGM. You can see that when you have a check mark, that means the patient did what the app recommended. When you see this triangle, it means the patient gave more than the app recommended. And in fact, you can see when the patients are late with their meals, or late with their insulin, I should say, you can actually see that. And these, in my view, they don't get enough credit. These have revolutionized our ability to take care of multiple daily injection patients, whether type 1 or type 2, because for the first time, we can see what they are doing. Now, this is a 32-year-old man. This was very recent. Type 1 diabetes for 22 years. He wore a pump years ago. He doesn't want to go back. He had a DKA episode in college. His A1C is now 6.8. He takes Degludec at bedtime with pre-meal Lispro AABC. That's the very fast-acting Lispro. It goes by the trade name Lumjev. He has a carb ratio. He has a sensitivity factor. Now, a sensitivity factor means 1 unit will drop you by 30 milligrams per deciliter. So typically we will tell patients if they're above 140, 150, take 1 unit for every 30 points. And that's assuming you didn't take your last prandial insulin 30 minutes before, because you don't want to insulin stack. And so this is sort of a typical thing on what we see here. And what do you want to do in this situation? Now, what I'd like to do is maybe I'm going to open up this for a moment. I'd like to pick on somebody here. I don't know. I'm looking. Does anybody want to volunteer what to do for this situation? Does anyone want to take the plunge? And I'll help you. I'll walk through it with you. How do you even start to look at this? John, you want to take a shot? No pun intended. I don't hear you. Uh-oh, how come I'm not hearing you?
Can you hear me? I'll try.
Oh yeah, go ahead. I hear you.
I guess I'm looking at this. And I'm seeing that, I don't know, I guess I look at the A1C and it doesn't seem terribly poorly controlled. And then what else am I seeing? I guess I'm trying to like think about, I know you sort of talked about the like proportion of patients like total insulin having the goal be like 40 to 45%. So I'm trying to kind of like get a sense of whether that's happening. And it seems like the basal is 20, and then in terms of the amount that on most days, whether it's hard for me to tell from this chart exactly like how much insulin he's getting for each of his meals, but maybe you can help with that.
Let me help you. Let me tell you how. First of all, whether you're just looking at finger sticks or you're looking at a continuous glucose monitor, there's no right or wrong way, but I'm just going to show you the way that I do it. The first thing I want to do is I want to look at the basal insulin, and I want to have that difference between bedtime average and morning average be under 30. So I look at the 308 and it comes down more than 30, but he's giving 5 units of insulin as a correction dose. So it's contaminated. And I look at the next day, I look at 295. Again, it's contaminated. It's coming down a lot, though. It's coming down, almost 200 points. But look at the next night. He's 142. He doesn't give any insulin for snack, which is the first zero. The second zero is the correction, and he goes from 142 to 66. And this is really common. He's getting too much basal insulin. Because you don't want it to come down more than 30 points. And by the way, in our smart pen that we use, it doesn't count the nights they take bedtime correction dose insulin. It only counts those days that are not contaminated by correction dose insulin, and it calculates what that beam score is, which is pretty cool. If we now look at the mealtime insulin, he is high the first day, the third day before eating, and the fourth day. And the only reason why he's not high on the second day is he took correction dose. So he's either not getting enough insulin at breakfast, despite too much basal insulin, he's not getting enough prandial insulin, or he's not waiting long enough, or both. And he's using the ultra fast acting insulin. It looks like his lunchtime insulin is good with the correction dose, but he's usually high here, and he's high at bedtime, and he doesn't give correction dose. It looks like he needs more insulin at bedtime. And so the bottom line is that it looks like he needs more mealtime insulin for breakfast and for dinner, and he's getting too much basal insulin at bedtime. That's what it looks like to me. But that's how you would look at this. Does that all make sense?
Yes.
Okay. Now, I don't expect anybody to be expert on this. If you go to the East Coast of the United States, they are using a lot of automated insulin delivery, AID, in type 2 diabetes. We are actually just within the next few weeks, we are about to start a study of automated insulin in type 2 diabetes. But like I said earlier, this is north of 70%. There are 4 of these systems now on the market. The one I'm showing here is the Tandem Control IQ. The pump communicates with a sensor, and they work by modulating the basal insulin in different ways. Each of these systems have a different algorithm. They all have their own quirks. And right now, the patient still needs to bolus for their own meals. The data shows that even in adolescence, the time and range on the continuous glucose monitor, which is between 70 and 180 milligrams per deciliter on the continuous glucose monitor, that even in these very difficult patients who don't bolus very well, they're just very hard with their diets and so forth, that we can get them to target with these systems. I mean, these are game changers. These have revolutionized the way we take care of diabetes. And this has really only become a major part of our clinic within the last 3 years or so. It has just revolutionized type 1 diabetes management. The bottom line with these AID systems, and the reason why they work so well, is that insulin requirements change every minute of every day, which are beyond the control of our current technology until now. Realize with these pumps, there's no long-acting basal insulin given. It's all short-acting, rapid-acting analog into the pump. And then the sensor tells the pump what to do. So this is the same patient on 2 different nights. And what you see is you get different basal modulations to keep that blood sugar in the green. This is a Medtronic pump. One day you're getting no insulin, another day at the same time you're getting a lot of insulin to keep the blood glucose in target. And we see this over and over and over. These pumps are able to modulate the basal to keep the time and range above 70 and the A1C below 7. Now, just a quick comment about A1C. With the continuous glucose monitoring, we use this term called glucose management indicator. It is simply using the average of the continuous glucose monitoring to give us an estimated A1C. The FDA would not allow us to use estimated A1C, but it's a metric calculated from the CGM-based formula from a population of mean glucose. And every app, every download, when we look at the continuous glucose monitor, it gives us a GMI, which is the estimated A1C. And what we did, and I actually did this with an internal medicine resident who is now an attending endocrinologist at Johns Hopkins by the name of Jordan Perlman. Maybe some of you know Jordan, but we took 641 of our patients here in our clinic, and we looked at their A1Cs and we compared it to the GMI. And I just want you to see the huge amount of scatter between the mean glucose and the measured A1C in the UW lab. Only 11% of the patients was the GMI and the A1C exactly the same. In 50% of the patients, it was more than a half a point off. So what that means is that if the GMI or estimated A1C was 7.0, which means an average glucose of 154, 50% of the patients would have an A1C in the lab measured by as over 7.5 or under 6.5. And by the same token, 22% of the patients, if the estimated A1C or GMI was 7, in 22% of the patients, the measured A1C from the lab is going to be above 8 or below 6 if the GMI is 7. And this is a huge problem. If you don't know that for any individual patient and you make a decision you are going to add a drug or subtract a drug for somebody with type 2 diabetes, or it's somebody with renal insufficiency where they're going to usually, but not always read low. This is just a huge, huge problem if you don't know if there's discordance between the A1C and the actual glucose levels. I should point out that we use this to make adjustments in people's therapy. We use this to tell women it's safe to get pregnant. And we use this number to grade doctors in terms of how well they're doing with their patients. I don't want to get too much into an editorial about this, but this just points out that for many patients, the A1C can be extremely misleading. So what about type 2 diabetes? Well, first of all, you want to make sure they have type 2 and not type 1 diabetes. And I would say the same is true going the other direction. GLP-1s are the first injectable on the ADA's algorithm and around the world for all the medical societies based on the data with GLP-1s. And it's actually the first injectable for anybody with type 2 diabetes except women planning pregnancy. I mean, this is the data. And I saw data that we are going to put in an abstract when we talk about GLP-1s data from a very large database of millions of people. And both for the GLP-1s and the SGLT2 inhibitors, where about a third of type 2 patients in the United States are now using these drugs. So it has really increased in the last couple of years. So with that being said, when to use insulin in type 2 diabetes? Well, certainly for uncontrolled or symptomatic hyperglycemia, blood sugars not controlled despite appropriate diet and exercise, education and medication use, uncontrolled hyperglycemia, and they either can't afford or tolerate the GLP-1 receptor agonist. Any insulin use, even basal insulin alone, Medicare now covers the continuous glucose monitoring, and so do virtually all of the other insulin carriers. What this means, if you're in your continuity clinic, there are very few patients that won't qualify for a continuous glucose monitor. I will acknowledge sometimes it's a lot of work on the physician's part to get them the CGM, but this is game changing both for you as the clinician and for the patient. I was just working on an abstract last night that we're going to submit with thousands of patients. It makes a difference right away in these type 2 patients, right away. And there's a lot of data on this, and I know I'm running out of time, but this is just showing what happens with CGM in type 2 patients. In the green, you can see what happens when they're on the CGM compared to the orange when they are not. And 59% of the CGM compared to 43% of the BGM were time in range. And it's the equivalent to over 3.5 hours a day with time in range between 70 to 180. This is data that I was involved with. I was the senior author. And the bottom line is within a few weeks after getting a CGM, we see this dramatic reduction of adverse diabetes events and all-cause inpatient hospitalizations for 2,400 patients on multiple daily injections with type 2 diabetes. The CGM makes a difference, and it actually lowers overall costs. Now, we talked about the beam factor a moment ago. You know what it is, but there's actually good data in type 2 diabetes that we have this beam number. What should the target be in type 2 diabetes? Well, this was really 2 studies in one, and I want you to see that when the beam increased to over 60, it's due to a lower fasting without a change in the bedtime glucose, which makes sense because you're just using basal insulin. And so you see this change in basal from the baseline. And this is the most important slide I want you to remember. The higher the beam score, the higher the A1C, and the higher the contribution to postprandial hyperglycemia. It's 72% in A, 69% postprandial hyperglycemia in B. But since they're not getting mealtime insulin, most of those with high A1Cs are clearly over-basalized. And what this is saying is that if you have a beam score above 60, it's all postprandial hyperglycemia, and you essentially can't get the A1C under 7 if you have a beam score above 60. Now, I'd rather see the beam score at 30, but what that high beam score means is that they're high with their blood sugars going to bed, and you're using the basal insulin to bring the blood sugars down from the bedtime hyperglycemia. If that difference is more than 60, the data says you need dinner time insulin, and I would rather have it closer to 30 because that's really the only way to go. So the bottom line is in type 2 diabetes, it appears a beam level over 60 is associated with A1Cs above 7. Should the goal in type 2 diabetes on basal be a beam less than 60? I think yes. It's the very first thing I look at in all patients, type 1 or type 2, is what is that beam score? So let's go through this patient. And again, there's a couple of other things. I know I have a few more minutes to go. It's a 55-year-old woman. It's very much like the last patient. We're going to look at what to do with the insulin. She is on metformin. She's on diabetes for 8 years. She's trying to limit her carbs. She's trying to do as well as she can with what she's doing, but her endogenous insulin is wearing off. and her A1C is trending up. She comes in with 2 adult children. Her A1C's over 11. We put her on a CGM. Her mean glucose is 311. So her 11% A1C is concordant. With much encouragement, she agrees to start bedtime glargine, as she was concerned about a few years ago. There was a concern about pancreatic cancer with the GLP-1s. So we titrated up to 55 units at bedtime. She's remained on metformin. She's gained weight, and you can see what happens. She's on bedtime insulin alone. And look what happens between bedtime. If you're just looking at her fasting, you think great, but look how high she is later in the day. And so, what are you going to do? Are you going to add an SGLT2, a DPP4, sulfonylurea, or prandial insulin? Now, I was going to open this up, but because of time, I'll just say it was decided to add the SGLT2 inhibitor due to she didn't want to take a shot. She didn't want to, she was concerned about pancreatic cancer, and she liked the idea that she could lose a little bit of weight on the SGLT2. And here she is now on 25 milligrams of empagliflozin. She's now lost a little bit of weight, and you can see with the basal insulin and the SGLT2 inhibitor, she's still high at bedtime. She's coming down way too much overnight. She's on too much basal insulin. But let's do a reality check. Her insurance won't pay for an SGLT2 inhibitor or a GLP-1. So now what do? Well, now we go back to where we were, and she had no effect from, and it was decided to try a sulfonylurea. It did nothing to her. And this is real life. What happens is that you have these plans, but you can't get her the tools that would help her the most. And so what we did was we got her unbranded Lispro, which you can get on goodrx.com for $20 a vial. You can get very cheap. We explained to her correction dose. We told her to take 1 unit for every 30 points above 150. And at bedtime, to start the correction doses, not at 150, but at 200. And because she's getting too much glargine, we decreased it because she's going down over 60 points. So it's not so much that we're giving her more insulin, but we're redistributing her insulin based on her blood sugars. And, in our clinic, everything is done electronically. We download meters in the CGMs, but there's nothing wrong with the good old-fashioned logbook. Dory and I did that for decades, and it works. But I would also argue, given the fact that she qualifies for a CGM with almost all the insurance carriers now, she would do better with that. I just want to point out that these drugs have been something else other than the weight loss that we see in the Hollywood actors and actresses. They have revolutionized diabetes, and they work very well in combination with basal insulin, extremely well. And as I mentioned earlier, we have these 2 drugs with the fixed mix, the Iglar-Lixi and the Ideglira. These are basal insulins with GLP-1s. It used to be somebody would come in with a double-digit A1C above 10. We would always start just usually basal bolus. We don't have to do that anymore because we can give them 1 injection of a daily basal insulin with daily GLP-1. And you can see from the data, you get these dramatic A1C drops when you use the 2 together. I also should point out, with everything negative I said about A1C, for a population, an A1C is very good if you're looking at a clinical trial, if you're looking at your practice. But if you're looking at an individual, unless you have a CGM to show the A1C is concordant or not, you don't know what that A1C really means. Not surprisingly, when you use the GLP-1 by itself, you get weight loss. When you use the GLP-1 with the basal insulin, you mitigate some of the weight gain you get with insulin alone. So these drugs are very good. They're generally covered, and I don't think we use them enough. These are the 2 that we have. There are recommended starting doses if you're on insulin before or not. and I'm not going to get into any of this, but since these are daily insulins and daily GLP-1s, it's very easy to go up and down and to titrate it. And it's not only titrating with the glucose, obviously, it's also potentially titrating with any GI side effects from the GLP-1. We have two of these. These are more details than you need, but you need to know that these are out there so you can put these two together. So the last points to consider. You see a lot of pancreatic diabetes. They are lacking insulin and glucagon, so they're more sensitive to life-threatening hypoglycemia. We talked about steroid-induced diabetes and the fact that they do very well with NPH insulin in the morning, and never, ever, ever be afraid to ask for help. Now, I want to end with this final case. I see we have a few more minutes. This is a patient I saw last week for the first time. She's 72 years old. She presents with a STEMI a few weeks before this. She has no known history of diabetes. In the hospital, her A1C was 12.4. She didn't know she had diabetes. She was started on insulin. She was sent home on a combination of glargine and metformin. I see her a month later. This was last week I saw her. She's now on a very different diet. She's testing her blood sugars 3 to 4 times a day. She's not on a CGM when I saw her. Her blood sugars are all in the 120s and 140s. What do you want to do? And I actually want to see everybody. So this is the patient. She's got a high A1C. She's on glargine and metformin. Blood sugars 120s to 140s before meal blood sugars. I'm seeing her in the clinic. She's on insulin. What do I want to do? Nikki, I'm going to ask you.
You have the prompt still pulled up?
You want me to pull the patient up again?
Yeah.
Okay.
I mean, it seems like she's made really great progress with her diet. So I think like the first thing is seeing how you can further support that and make sure that that's like healthy. If she's lost weight, make sure that's healthy. See like if there's any other factors or she could benefit from dietitian. I know part of this talk is like thinking about being more comfortable with insulin, but my other thought is that fact that she kind of got fairly decent controlled in just 1 month is, could we potentially transition her to some of these other like oral or injectable agents rather than keeping her on insulin just for their other benefits? But I know that process takes time too. So I would see if we could transition her to at least a GLP-1 and then potentially an SGLT2 as well to try to minimize her insulin need for as long as possible.
Why a GLP-1 or why an SGLT2?
After the STEMI, like we didn't get any of her cardiac history, but both have some evidence for benefit after cardiac events. So like SGLT2s are part of GDMT for heart failure. We weren't told if she had any heart failure, but my understanding was there's also
no heart failure.
My other understanding was that GLP-1s are like there's more and more data for cardiovascular protective effects of GLP-1s in patients with diabetes as well.
Right. So let me tell you, you're right. And the big issue here is the fact that these drugs have been shown to reduce the risk of subsequent cardiac events, 3-point MACE, and cardiac death. So yeah, I want her on a GLP-1, but there's a big issue here. She's changed her diet, she's on insulin, and she started with an A1C in double digits. What happens? This was first described in the 1980s, and the more important teaching point here, when you see somebody and you start them on insulin and they have a double-digit A1C, usually it's double digits, it can be above 9%. We don't know how long she's had her diabetes. She didn't know she had it. You bring the blood sugar levels down too quickly, you can have an explosion of diabetic retinopathy. It has to do with the fact that the retina becomes hypoxic and ischemic, And what you see in the eyes are something called cotton wool exudates. And that's pathognomonic that you've brought the blood sugars down too quickly. Well, it's really hard to get an ophthalmology appointment. Fortunately, her husband is extremely, extremely well connected. She had an ophthalmology appointment literally the next day, and she had cotton wool exudates. Cotton wool exudates, meaning, and they weren't many, but you don't see that for any other reason except these little micro infarctions in the retina. So she drank the Kool-Aid. She was literally and figuratively sugar-free Kool-Aid. She was doing everything she was asked to do, but that wasn't a good thing starting with an A1C of 12. And so I know she actually has a risk of blindness. So I need to put the brakes on her blood sugars. I do want her on a GLP-1. I'm actually going to see her tomorrow. And what I'm going to do is I'm going to stop the insulin and put her on a GLP-1 on a low dose. Her blood sugars are too well controlled. And I don't think most of it is the insulin. I think most of it is the diet. Anyway, I did a lot of stuff. It's exactly 10:10. I want to know if that was helpful. I also want to know if you have any other burning questions. I see 16 comments in the chat, which I didn't see any of them.
The good is I guess a couple of questions. One is about like the comparison of CGMs and A1C. Do you consider the CGM to be the gold standard versus a measured A1C? And piggybacking off of that, are you ever worried that in-hospital A1Cs are not accurate?
Oh, we knew. Well, yeah, I mean, this is an entire talk, but yeah, the only reason I measure A1C on any patient is for the insurance company. There's no other reason. Now, having said that, we are now doing research where we are showing that the ratio of the measured A1C, it's actually the GMI, the estimated A1C over the measured A1C, actually is an amazing predictor of who's going to get eye and kidney disease. And it has to do with the fact that if you are binding glucose to the hemoglobin quickly and you're a high glycator, you're probably doing the same in the retina and in the glomerulus. And what we're finding out is that if you use both of them as a ratio, you can tell who's really at risk for microvascular disease. But yeah, the GMI has become, in my view, the gold standard. And considering the explosion of CGM and insulin users in high income countries in Europe and in the United States, it's becoming everybody's gold standard. Depending on why the patient is admitted to the hospital, the A1C may or may not be helpful. In the transplant patients, they're receiving Dapsone, Bactrim. They will both. I had a transplant cardiologist call me a week ago. He had someone with an A1C of 3.9. Well, the patient was on Dapsone. There are so many reasons why the A1C can be off in these sick patients. It's an outpatient test. It was a great test when we started using it in the 80s and 90s. And what we're learning is it's not as good as we thought it was. Oh, and by the way, African Americans run a half a point higher for every glucose. And we don't even know about other races and ethnicities, but it also depends on your race and ethnicity.
I have a quick question about the GMI. So we in the primary care track got to wear glucose monitors ourselves for a period of time. And I think a lot of our GMIs were like higher than we thought they would be. And so and then I sort of looked into like the difference in the algorithm between the GMI and the A1C, because I've gotten an A1C done and it was much lower. And so I'm curious to know, like, for folks who don't have diabetes or who have more well-controlled blood sugars, is there going to be some like abnormalities in the GMI, or maybe not? Maybe our GMIs were indeed that high.
Yeah. First of all, it also depends on what sensor you're wearing. The two most recent sensors now do a very good job. But especially with the Abbott Libre in the past, they were off. All of the sensors don't read well the first 12 to 24 hours. But whether you have diabetes or not, You are glycating hemoglobin. Not everybody glycates hemoglobin the same way. That's problem number one. Problem number two is that the lifespan of the red blood cells are different in everybody. And not only that, we actually did a study looking at this, and we found 5% of the population had elevations in reticulocyte count, which was really interesting to me. So between the red cell issues with lifespan and differences in glycation, it's not surprising that some people read high with the A1C and some people read low, whether you have diabetes or not. I trust, as a rule of thumb, with today's CGMs, I trust the CGM more than the A1C by far. And
I should be
by the
worried.
way, you're diagnosing diabetes on a test that I don't believe in. And I had this concern, and many of us around the world had this concern in 2009 when the ADA said we're now going to diagnose diabetes by A1C. That's great for a population, but what if you're African American? It doesn't work. It makes no sense. Anyway, I hope this wasn't all too confusing. My life with A1C has always been a problem.
This was great, Dr. Hirsch. I really appreciate getting your perspective. I think it's something all general internists need to know about, but as a budding primary care doctor, more about insulin is always appreciated. So
Yeah, and I just see that last comment. I don't know what to do about the race information. Either do I. When we look at here in Seattle, we see a lot of Asian Americans. Nobody has done the study on Asian Americans to show, do their A1Cs read high or low compared to white Americans. We don't even know what it means, which is why the CGM is so much better. Anyway, think about it. Thank you for the invitation. I'm glad I could share some of this with you.
Thank you, Dr. Hirsch. I put it in the chat for everyone, but Academic Half Day on October 26th, Dr. Wright will actually be bringing some continuous glucose monitors in. And so people will actually have a chance to put their hands on them.
Great. Okay, thank you again.
Thank you.
John, how would you feel about like 10:25?
I think that would be awesome. This is probably a good break for me to text Ken and tell him that he's up. So
I love a on the fly talk, you know. I'll see you then.
yeah, see everyone then. Think of really hard questions to stump Ken.
Search pleural disease for experts.
Yeah. Nikki, before you go, why don't you go ahead and hit stop and on the recording, and I'll take over the recording
Okay, I'm
for
gonna
Ken's
click
session. Yeah.
stop right now.